Good afternoon. I want to greet our scientists from Ukraine on this big anniversary of the 150-year anniversary of the Shevchenko Scientific Society. It's really a great opportunity to every country to create such a big celebration. I don't know too many societies in the world which have 150 years in their background. My presentation will focus on the update on the long COVID, which is, of course, the long-term consequence of acute COVID-19 infection. It's a new disease, a new syndrome, which is now still bothering most of the medical scientists around the world. So in my presentation, I will show a typical case of long COVID, provide a definition of long COVID syndrome, because essentially, since this is a complex series of diseases and signs and symptoms, I think it's better to call it syndrome, not just long COVID disease. And review very quickly the presenting signs and symptoms, and then touch on the prevalence and incidence of long COVID. And since we are the basic scientists and working always on the pathogenesis, I will show the little we know so far about the mechanism of disease, touch on the clinical manifestation and treatment possibilities, and what is really the latest meaning definitely on the November and December of 2023. A year ago, the New Scientist, a journal in the UK, showed this front picture beating the long COVID. So this essentially shows that indeed it's a big international problem. And here is a typical case which you won't believe. It was published in a Sunday edition of the Los Angeles Times, because I'm recording from Los Angeles, not from the beach, but essentially from our offices at the American University of Health Sciences. This was a typical case of a young boy, 13-year-old Amit Cohn, who get an acute COVID infection, and it essentially lost most of his ability to follow the school and social activities. And this case is essentially highlighted here. Rather than to read this text, I highlighted the most important part. He is now isolated after testing positive coronavirus and waiting a nagging headache, which didn't disappear. The kid, Amit, thought that everything should be fine, as most of his cure indeed became healthy again. But instead, this teen boy grew sicker and sicker, suffered from nausea, dizziness, headache, lung inflammation. And his parents took him one doctor to other, but nobody could really help. So essentially, he continued to endure this long COVID with symptoms that persisted for weeks, months, and more than a year also. And actually, this kid, after a year, he started to regain, but only after 1 year, started to regain his physical strength. Thanks mostly to the parents' credit, who took him a cardiopulmonary rehabilitation, and probably some medication, vitamins, and other therapies. But the kid is still grappling with brain fog and he faltering memory, so he cannot go to school effectively. So the kid is saying, I could remember what I was doing in the math class, but I cannot remember what I have learned. So this is really a very tragic case and affects people of all ages. So what are the definitions of long COVID? The initial definition was new signs and symptoms occurring 4 to 8 weeks after the acute stage of COVID-19. Where more recently, during the last year and a half, now is defined officially as presenting signs and symptoms and or new malaise, completely new malaise starting after 4 weeks, despite the therapy. And a French group about a year ago added another requirement for the definition, and that is that the COVID-19 must be proven by the positive PCR or an antigen test. So it's not enough to to just pronounce that the patient is a COVID-19 sufferer. This group published in the JAMA last January showed that indeed it has to be lab test proven. And again, as I mentioned at the very beginning, is not a simple disease, but this manifestation of dysfunction of several organs. Hence, it is a syndrome. And the sobering statement was the national newspapers a few months ago. Long COVID is large, it remains a mystery, but a few clues are emerging. So what are these few clues? This is a summary of the long-term effect of COVID-19. As you see from the illustration, from the size of the circles, the most prevalent is fatigue. 58% of the patients are affected. Then headache, attention disorder, anosmia, memory loss, including even hearing loss. So it's a crucial disease which is essentially has more than a dozen of symptoms. The laboratory findings are not consistent, but what is most prevalent is this, the elevation of D-dimer, and some of the other laboratory findings in prothrombin time. But these laboratory findings are necessarily not consistent, so it's mostly the essential is that the patient is proven to have an acute COVID-19. So what is the evolution of this acute subacute signs of COVID-19 into long COVID? Dr. Roxana provided me this review article recently, published actually in November, from a Belgian group of investigators in November 2023. It shows very nicely that although in the initial acute subacute presentation, there are of course neurological signs which essentially lead to memory disturbance and brain fog. The respiratory syndrome go into dyspnea and cough, which can last for years. Cardiovascular symptoms, palpitations, orthostatic hypotension, chest pain are prevalent. GI problems are not frequent, but it still can be seen in vomiting, in diarrhea, like this case showed also. And the musculoskeletal symptoms acutely essentially transferred into muscle pain and muscle weakness. And the systemic symptoms essentially are the chronic fatigue syndrome we see in the long COVID. So what is the prevalence and the incidence? The prevalence, of course, is the total number of cases of any given time and place. Incidence is the development of new cases. The initial prevalence in 2020 was 3 to 30% among COVID-19 patients around the world. So as you see, this is not a new disease completely. By the end of 2020, we knew there is a chronic stage of the acute COVID-19 infection. The recent data from the United Kingdom shows that 2.5% of the entire English population is suffering from various forms of long COVID syndrome. And this is not just the people who had acute COVID-19, but the entire population. And the good news from Israel is that prior vaccination offers some protection against long COVID syndrome, but it may still occur even in 25% of the fully vaccinated people. So vaccination does protect, as this Israeli data show. 54% is less likely to report headache, 64% less likely to have fatigue, 68% less likely to report muscle pain. So vaccination does help. So anybody is still thinking about getting a COVID booster, they should do it by all means. So what is the pathogenesis, the little we know? Since I was interested in acute vascular injury and gastroduodenal ulceration, I followed this literature very clearly, and I was very pleased, in quotation mark, to see that vascular changes, increased vascular permeability, is a very early stage of the COVID-19 infection. And this is due to the fact that the endothelial damage is altered, damaged by the virus, and this is the normal lung alveoli. Although the initial cells are the epithelial cells which are first affected, but the virus propagates and involves the endothelial cells in the lung alveoli also. So if the vascular permeability is increased because of the release of VEGF, which was initially, when it was invented, was called vascular permeability factor. And VPF is even more active than histamine in increasing vascular permeability, and it accumulates in the alveoli, and that's the reason patients have initial difficulty of breathing. If the release of VEGF persistent, of course, it leads to proliferation of fibroblasts and essentially lung fibrosis. And the chronic stages, this vascular permeability is subsided a little bit, but still the virus essentially is embedded in the endothelial cells, and there is a constant immunoreactions going on, which essentially creates a chronic infection in the lung also, which is the result in dyspnea and other breathing difficulties. So what is the typical presentation based on the large number of experience of Professor Veronika Müller in Budapest, who is a collaborator of an ongoing big international study that I'm going to mention at the end. So she said that a post-COVID-19 condition occurs individual with history, but probably confirmed SARS-CoV-2 infection, 3 months of the onset, or at least for at least 2 months, and cannot be explained by any other alternative diagnosis. So it's a very important reminder that this is a diagnosis by exclusion. So all other possible reasons for the COVID-19 of this condition should be excluded. The most common symptoms include fatigue, shortness of breath, and cognitive dysfunction, but other general symptoms can occur also. And this may be a new onset or following the recovery from acute COVID-19 or persist from the very beginning. And these symptoms can fluctuate or relapse over time, but usually they don't disappear. So what to treat in these multi-organ diseases? And this is also from the Professor Veronika's slides. Of course, you try to treat, first of all, the fatigue, dyspnea, myalgia, and cough, which are the most prevalent. And based on the other presenting signs and symptoms, we might need to treat other signs of symptoms also. And all this requires a multidisciplinary action. So no cardiologist or pulmonologist can treat everything. Fatigue should require cardiopulmonary resuscitation and muscular system neurology and psychiatrist intervention. Dyspnea, cough, and chest pains needs cardiovascular and respiratory intervention. Headache, of course, is referred usually to neurologists if general practitioners cannot treat. And myalgia pain, joint pain for rheumatology, and altered smell refers to ear and nose and throat, ENT specialist, and diarrhea belongs to the gastroenterologist. So what is the latest, which actually latest meaning definitely November and December of 2023? The good news is the prevalence data surveys completed by the CDC, the Center of Disease Control and Prevention United States, monitored, these people monitored from June 22 to June 23. And the prevalence decreased to 6%, irrespective of the history of the previous COVID-19, decreased from 18.9 to 11 point. But a long lingering symptoms remained even after viral infection, but the prevalence is much higher after the SARS-CoV-19 infection. The mechanism of pathogenesis is what emerging from several sources around the world is that this virus often remains hidden in various organs, where it stimulates immune reactions that leads to tissue injury and impaired function. This is very rare, but essentially could affect with other viruses remain persistent in the body, but SARS-CoV-19 is pretty persistent on hiding in the various organs. And this is the CDC data illustrated from June 22 to June 23. Is decreasing in most of the age group, but in the most the statistic, because some of them are increasing, the overall statistical analysis showed essentially it is leveling off. It was decreasing in 2022, but now it's steady, involving about 6% of the population. What is especially important both for clinicians or anybody who is dealing with long COVID-19, that it leads to severe activity limitations. People just cannot work, and especially affects the working population, age 40, 50, and 60. And overall, all adults have about 1/4 of them have impaired limitation. The essential just cannot work, including our young kid I presented initially. So what is the take-home message, a summary, the conclusion? Ladies and gentlemen, please let's remember that long COVID syndrome is a constellation of non-stop symptoms such as fatigue, shortness, and brain fog after COVID-19. But please, let's not use long COVID as a loose diagnosis. It is a diagnosis by exclusion, especially after poorly defined chronic fatigue syndrome. The long COVID syndrome can be rendered only, but only after SARS-positive laboratory PCR or antigen confirmation. The pathogenesis of this syndrome is poorly understood, but vascular factors, immunologic abnormalities play a major role. The question remains, are post-infective symptoms specific to SARS-CoV-19 or not? That remains to be seen during the next few years. The multi-system symptoms need a multidisciplinary treatment approach. One clinician probably cannot treat everything. Thus, we conclude that a long COVID may appear as a mysterious, but objective definitions of the syndrome is being developed in addition to diagnostic criteria and therapeutic possibilities. Just a few words about the future. Yes, long COVID is a complex and poorly understood syndrome, but research and investigation should help. We put together an international team of public health and clinical investigators, as well as basic science researchers in the project on the public health and socioeconomic implications of long COVID-19, an international collaborative study. And thank you for the help of Professor Oksana Zayachkivska. Ukraine is very prominent in this study, in addition to 3 other countries in Europe, Germany, Hungary, and Greece. We have 2 countries from Africa and 2 from Asia and 2 from North America. In addition to United States, Mexico is also involved. And we have 5 specific aims to design the prevalence and incidence of organ distribution long COVID over a long time period, at least for 5 to 10 years, to monitor nutritional deficiencies that might be associated with complications of long COVID, and especially focus on endocrine changes, especially adrenocortical and gonadal insufficiency, and especially the new emerging post-COVID-19 stress syndrome. And of course, we want to provide technical assistance to scale up public health readiness and identify targets for intervention, prevention, and future research. So, ladies and gentlemen, thank you again for the invitation to participate in this very prominent scientific meeting. Congratulations to all of you for the 150th anniversary of the Shevchenko Society. Best wishes for another 150 years and many more. Thank you.